Good afternoon. Today my talk is on platelet indices, which are potential novel biomarkers in clinical medicine. First, I'll briefly introduce what the platelet indices are. Then I'll describe a bit about their use in clinical evaluation. Whenever we order a full blood count, just like red cell indices, platelet indices are there. However, we rarely read beyond the platelet count. And this is the part I'm going to highlight today. A number of studies are done on platelet indices and their use in clinical practice, and the findings suggest that they are a good adjunct in disease diagnosis and prognosis assessment. The commonly used platelet indices are mean platelet volume, platelet free, platelet to large cell ratio, and platelet distribution width. Additionally, in some full blood counts, there is another index termed immature platelet fraction. Just like all the other laboratory investigations, the reference ranges should be adjusted according to the patient's age and gender, but this is yet to be done with regard to platelet indices. Reference ranges now used at these full blood counts depend on the analytical method. First index is the mean platelet volume, which is the average size of platelet in peripheral blood. Size usually ranges from 6.5 to 12 femtoliters. This is a marker of platelet production rate and platelet activation. So if there is low production of platelets, this leads to activation of immature platelets, which in this process, platelets develop pseudopods. When pseudopods are formed, the platelet size will increase, leading to an increase in mean platelet volume. So if there is ongoing low platelet count with high mean platelet volume, that indicates there is likely peripheral destruction of platelets. And if there is low platelet count with low mean platelet volume, that indicates there is bone marrow suppression. If there is a rising trend in mean platelet volume, that indicates that platelets are recovering from previous bone marrow suppression. The next index is platelet free, which is the platelet index similar to hematocrit. This indicates the volume of platelets as a percentage of total blood volume. This is calculated as platelet count into mean platelet volume divided by 10,000, which gives a value between 0.108 to 0.282%. Platelet kit generally parallels the platelet count. There's another index termed platelet mass index or PMI, which is similar to plateletocrit. This is calculated by dividing the platelet count into MPV by 1000 instead of 10,000 as I said earlier. And this platelet mass index is used as a marker for inflammation in studies with regard to patients with gastric cancer, preeclampsia, and COVID-19. The next index is platelet to large cell ratio. This indicates the percentage of platelets with a size more than 12 femtoliters. As I said earlier, once platelets are activated, their size increases. So these large cells are the metabolically and enzymatically active ones. In a normal person, this ranges between 11% to 45%. PLC are directly related to the mean platelet volume and the platelet distribution width, and is inversely related to the platelet count. So if the patient has elevated platelet count, the PLCR value is low, and if there's low platelet count, there's an increase in PLCR. Next one is the platelet distribution width. Just like red cell distribution width, this is the direct measurement of the variability of platelet size, which lies between 15 to 17%. This increases with change in platelet size. As I said, if there is platelet activation, an increase in platelet size will occur, which in turn leads to an increase in mean platelet volume and then a rise in platelet distribution width. The last index is the immature platelet fraction. It is the percentage of young immature platelets. This is similar to reticulocyte count in red cells. Immature platelet fraction usually increase if there's platelet count rise, suggesting that there is a release of immature platelets from the bone marrow. So if there's bone marrow suppression, there's a reduction in immature platelet fraction. Now we'll see how the platelet indices are applied in clinical medicine. As you can see here, the majority of studies are done among patients with cancers. However, I'll discuss a bit about commonly seen diseases in our medical wards. First disease is the dengue fever, and studies regarding platelet indices are done among patients in India, Sudan, Colombia, and Thailand, representing main three continents affected by dengue fever. As we all know, low platelet count is a laboratory indicator to diagnose dengue infection. However, we still don't know the mechanism behind this low platelet count. There are several theories postulated. One is whether there is direct suppression of bone marrow by the dengue virus. Secondly, whether there is antibody-mediated platelet destruction. Thirdly, whether there is isolated viral replication in the platelet. Fourthly, if there is peripheral consumption of platelets. Either one of them or combination of them can be the cause, or there can be another mechanism which we still don't know. So the exact mechanism is yet to be found. So if there's low platelet count with persistently high mean platelet volume, that suggests that the patient has active dengue infection. And if there's an increase in mean platelet volume with a stable platelet count, that indicates recovery from the infection. In all dengue patients, there's a rise in PLCR, but if it exceeds more than 42%, it is highly sensitive for dengue hemorrhagic fever. Similarly, in all dengue patients, there's an increase in platelet distribution width, but if it exceeds more than 15, that is more sensitive for dengue hemorrhagic fever. So in dengue, in summary, in this table, I have there is if low platelet less than 0.15% with high platelet to large cell ratio more than 42, with a high platelet distribution with more than 50, these are more sensitive for dengue hemorrhagic fever. Second disease entity is the cardiovascular disease. We all know that platelets play a major role in coagulation, inflammation, thrombosis, and arteriosclerosis. There have been a meta-analysis done among 105 studies published from 1950 to 2008. And here there was a systemic review and meta-analysis with 16 cross-sectional studies to assess the association of mean platelet volume in acute myocardial infarction. There they found out that the mean platelet volume is significantly higher in patients with acute myocardial infarction when compared to the controls without acute myocardial infarctions. Similarly, in subgroup analysis, they found out there's a significant difference in mean platelet volume among patients with acute myocardial infarctions when compared to stable coronary disease as well as among healthy controls. However, there's no difference noted among patients with acute myocardial infarction and unstable angina. With pooled results from 3 cohort studies involving 3,000 patients, they evaluate the risk of death following acute myocardial infarction. Here also, findings suggest that if there's elevated mean platelet volume, there's an increased risk of death compared to patients with normal mean platelet volume on admission. Similarly, there was another study with pooled results from 5 cohort studies among patients who undergo coronary angioplasty. Here also, if there's a higher mean platelet volume during the angioplasty, they tend to develop restenosis than the patients who have normal mean platelet volume. Another study was done among patients with pulmonary embolism, involving 70 patients with pulmonary embolism and 75 controls. Here also, the findings were that patients with pulmonary embolism tend to have a higher mean platelet volume and higher platelet distribution width. So if we combine the mean platelet volume and platelet indices with D-dimers, it can increase the specificity and positive predictive value of D-dimer for pulmonary embolism. In this study, they found out even though among patients with pulmonary embolism, the platelet count is normal, in severe pulmonary embolism, the platelet count tends to be towards low normal range. There was another study done among patients with acute ischemic stroke, mainly among patients who undergo thrombolytic therapy. Here also they found out that if the patient has high MPV, mean platelet volume on admission, that indicates worse outcome at 3 months duration. Other common disease entity we see in medical wards is the diabetes. We all know that in diabetes there is impaired fibrinolysis and elevated procoagulation factors, which leads to enhanced platelet activity and potential diabetic angiopathy, be it macroangiopathy or microangiopathy. So when compared to non-diabetic patients, both patients with diabetes tend to have elevated mean platelet volume, platelet distribution width, platelet count, and platelet to large cell ratio. Even among patients with diabetes, patients with complications tend to have significantly high platelet distribution width when compared to patients without complications. There was another study done among patients with inflammatory bowel disease. Here they found out that if there is relapse of ulcerative colitis and Crohn's disease, these patients tend to have higher platelet count and platelet of width when compared to patients in remission and healthy control. When the findings are compared with ulcerative colitis and Crohn's disease patients, that indicates that patients with Crohn's disease tend to have a lower platelet distribution width when compared to patients with ulcerative colitis, and this might shed an idea on risk of thrombotic events among patients with ulcerative colitis. Here, they used an additional platelet index, as I said, platelet mass index, as a possible indicator of disease activity in Crohn's disease. This increase in platelet mass index may be due to the severe chronic inflammation and raised platelet activity and aggressibility seen in Crohn's disease patients. As the majority of studies done among patients with cancer, I talk a little bit about cancers as well. We all know that the platelet count in a patient with cancer will vary according to the type of cells involved, associated inflammation, and whether the patient is on chemotherapy or not. So in some cancers like gynecological cancers, lung, colon, and renal cancers, they have found out that higher platelet counts indicate aggressive disease. So the platelet activity and tumor cell activity goes as a vicious cycle here. More platelet counts present in blood tend to cover the tumor cells so that they are saved from sheer blood forces of the host so that the cells can evade the host immune response. Similarly, these tumor cells can secrete interleukin-6, which is a pro-inflammatory cytokine that induce thrombopoietin secretion, leading to increased platelet production. In this process, when the platelets are activated, increased mean platelet volume is considered a surrogate marker of platelet activation associated with inflammation, commonly seen in advanced cancers. However, variation of platelet indices is not uniform among cancer patients. You can see in ovarian cancer, the increased platelet distribution width indicates poor survival. However, among patients with gastric cancer, poor survival is indicated by significantly lower platelet distribution width. So in summary, platelet indices are commonly available and inexpensive biomarker which can be used as an adjunct in diagnosing and assessing prognosis of diseases. However, there should be an standardization of analytical method to ensure accuracy of data interpretation and application in clinical setting. These are my references. Thank you for your patience.